The ManVsProstate Crusade. What about my bladder? My objective today is to share with you the message about the ManVsProstate Crusade. The time is now for the BPH BPO care pathway to obtain bladder health baselines early on and upfront so that we can act with an appropriate sense of urgency to deobstruct the right prostates at the right time within the window of curability. My promise is that together we can affect positive change away from a drug-first approach to a data-first, pro-diagnostic, bladder-centric paradigm, allowing patients to prioritize their bladder health, make the best decisions about their prostate, and live their best lives chemical-free and catheter-free, because something has to change. There are too many bladders pleading for help. And so with that, we know this story. This is a story that we all can tell. For me, it's 3 a.m. in the morning at Loveless Hospital in downtown Albuquerque, New Mexico. I'm fast asleep and the phone rings to wake me up. It's the emergency room for this 72-year-old gentleman who now has 2.5 liters in his bladder because he has not peed all day, and he has been on Tamsulosin and finasteride for the last 12 years. The bothersome symptom is obvious. He can't pee. The bothersome fears are everywhere. His fears, the unknown, the terror, the pain, and my fears. Can I even get a catheter in? Do I need to put a suprapubic tube in? Fortunately, I recognize that with a catheter in place, at least it will temporize the situation and allow me to get him to clinic and do an evaluation. But my fears don't stop there. Is this one more bladder that's actually a dead bladder for which I have to light another candle in remembrance of? Is he one more man who's now been condemned to a life of catheters? And the reason why I'm concerned is because there is a tsunami of LUTs that's about to crash into our shores. Doing the calculations, a population of 10 billion in the year 2050, there will be 525 million men with moderate to severe LUTs, 65 years and older, who need our care. And we are not prepared, and we do not have enough urologists. So what can we do? Well, we do what we do best. We evolve, for we are not just human beings, we are human becomings. And the BPH care pathway needs to evolve as well. And how do we do it? Well, we use language. We have learned this from the urologic giants like Defenders, Alan Wien, and Abrams. They taught us that words shape thoughts, which shape actions, which shape habits. That's why unstable became overactive bladder. Prostatism became LUTs. So let's do the same. And it starts with understanding who are we, because we are defenders of the detruser. We took a solemn vow to preserve bladder health, to prevent late-stage BPH BPO, and to end the polypharmacy epidemic. Our battlefield is the landscape of male LUTs, and for us, the bladder is in the center. It is the cornerstone. It is what we choose to protect and defend it against overactivity, underactivity, dysfunction, and damage. Yes, and it is very complex. There are many other factors, such as aging and metabolic syndrome, a la Defender Gonzalez's insights. We are grateful for the academic leadership, experience, and expertise, for all their evidence-based words that guide us to manage lower urinary tract symptoms and benign prostatic hyperplasia. We offer our support of all their expertise and experience with our community-based ManVsProstate manifesto titled The Preservation of Bladder Health for BPH BPO Patients. We choose to keep the acronym BPO in place because it reminds us of what we do best. We are solution-finding surgeons. We deobstruct. Like with a UPJ obstruction, a blocked kidney, we deobstruct to preserve kidney function. And that's for an organ that actually has a spare on the other side and is transplantable. We are doing the same for BPH BPO because we are deobstructing to preserve bladder function. We've chosen to also keep BPH as a term in our manifesto. Yes, we do not treat histology, but it is a universally familiar term now for our patients. It optimizes the patient experience, which is our top priority. For us to drive good health policy, just like with UPJ obstruction, it requires good data, CT-IVP, MAG3 renal scan, etc., and good deobstruction like a pyeloplasty. We do the same thing here for BPH BPO, and it also includes the right dialogue. And that dialogue starts right now, today, when we want to preserve bladder health. It starts today at this 59th Congress under the visionary leadership of President and Defender Milton Salazar, who teaches us, hey, let us have this conversation, and it's really important that we have a battle plan. And you'll see that on the right. It's two parts: evaluation and deobstruction. For evaluation, there's counseling, there's triaging, and there's risk stratifying. And for deobstruction, it really centers around shared decision-making 3.0. 1.0 is where the urologist and the patient came together to have the discussion. And then healthcare came in 2.0, providing its input on what was available and what we could do. And then 3.0 is the bladder is pulling up a chair to the table of shared decision making as an equal partner with equal say to shape decisions, because it will take all four of us to find solutions for every patient. The bladder has asked us to define what we think is good health policy. So I looked at all the abstracts from the AUA Chicago meeting, and I found 4 elements. Treatment durability. When we look at minimally invasive, advanced invasive, are they effective? What is an acceptable retreatment rate? What is treatment failure? Economic sustainability. Every country, every practice, every physician must determine what is cost effective. Moreover, questions like, does the potential prevention of emergency room visits for a man in retention later on in life justify the initial costs of earlier deobstruction? Man's vitality. We espouse practicing a minimally invasive holistic medicine where we optimize a man's health, physical, intellectual, emotional, social, spiritual, and of course, sexual health. And then the window of curability, our favorite as defenders of the diffuser. How do we intervene at the right time to save more bladders? So when we put that all together, the answers are found in the sweet spot where there's the overlap between treatment durability, economic sustainability, man's vitality, and the window of curability, where everyone is striving for compromise to satisfy as many needs as possible, knowing that it is impossible to satisfy them all. To preserve bladder health will require that we do proper bladder health counseling. And the bladders ask that we keep the language simple for men. The prostate is the size of a golf ball in the shape of a mini donut. The heart is a muscle that pumps blood. The bladder is a muscle that pumps urine through the prostate. The bladder also asks that we highlight how amazingly unique the bladder is. There are only 2 major organs that you cannot transplant, the brain and the bladder. So yes, it's an organ that we need to cherish. Why? Because the prostate is merciless. It shows no mercy. It just keeps growing and growing tighter and tighter, 6% a year via the MTOPS placebo arm. And we see that there's this cyclical rise in bladder pressures, increasing, as well as increasing tissue hypoxia, leading to 3 stages of bladder remodeling: hypertrophy, compensation, decompensation. And we can see here in the first phase of hypertrophy, the smooth muscle hypertrophy and hyperplasia, and then the initiating of deposition of extracellular matrix over time through the compensation phase and through the decompensation phase, leading to cellular dysfunction and degeneration with overactivity and diffuser underactivity. But don't just trust a pretty picture. Trust our eyes. We know what a diffuser under duress looks like. Look at this progression from a healthy bladder. The truth of trabeculations and cellules and diverticuli as this disease progresses. Defender Amanda Chung has taught us, look at the ultra microscopic level, see the devastation and the destruction, because the bladder can only be a victim for so long for these crimes before it reaches a breaking point. This is a Sentinel paper 2020, Kaplan et al., 50,000 pressure flow studies, and it confirmed what we suspected. As that donut hole grows tighter and tighter, the flow decreases. As a result, the bladder compensates by having rising compensatory pressures until it reaches a breaking point, after which the bladder begins to fail and decompensate. If we look at a missed indication age of 45 years and the Qmax of less than 10 cc's per second, we magically see unveiled is a window of curability conceptually, and it compels us to ask, can we intervene before the onset of damage or before the damage is irreversible? It also compels us to ask, well, how do we intervene? How do we de-obstruct? To preserve bladder health, our battle plan has two de-obstructive approaches that we appreciate. Understand that de-obstruction is a combination of shared decision-making as well as the trifecta of surgical choice: detrusor function, prostate size, and shape. Academic leaders see surgery with the duality of invasiveness, minimally invasive, advanced invasiveness. Bladders see it as degrees of de-obstruction. What is the most you can do to de-obstruct? That is your maximal de-obstruction. Might be a green light, might be aquablation, it might be enucleation. Or is it some fraction thereof? That is your fractional de-obstruction. ITIN, UroLift, resume, whatever works for your system, for you and your patients and shared decision-making. So there's a duality of de-obstruction. We are so grateful for all these options that exist for fractional surgeries, as well as all these options for maximal surgeries. Several takeaways. One, the bladders are always going to vote for a maximal de-obstruction. They just want to breathe more easily, faster, and better. Shared decision-making 3.0, we recognize, though, you have to make compromises. One size does not fit all. Please have at least one option that you can offer for each of the approaches. Do them well and do a lot of them when warranted. To preserve bladder health, we need to understand bladder health by getting bladder health baselines. To get bladder health baselines, we need urodynamics to help us with triage and risk stratifying patients. Why? Well, the biggest problem at the table of shared decision-making is no one speaks the language of bladders. They may be speaking, but we can't understand. So we need urodynamics to be our bladder interpreters. And we applaud and uphold the academic definition of urodynamics. For our defenders, we offer this definition of any test that provides qualitative and/or quantitative data about bladder health. And breaks down to three categories. You have advanced, you have enhanced, you have basic. And there's a progressive increase in the quality and quantity of data over time, over the three categories. And with advanced, you have cystoscopy and you have multi-channel advanced urodynamics, which provides insight and data for both the filling phase and the voiding phase. For enhanced, it provides information about the voiding phase or the filling phase, but not both. And for the basic category, that is our workhorse that really drives BPH BPO care: diary, IPS, uroflow, ultrasound. Yes, look at things like detrusor wall thickness, PVR, prostate size, as well as newer technologies like bphtool.com. And together they allow us to build a foundation of the triangle of triage that allows us to look at symptomatic patients and identify criteria from basic urodynamics that would trigger a bladder health baseline. Is that bladder at risk? So urge incontinence, spontaneous retention, IPSS 8 and above alone or in conjunction with Qmax less than 15, PVR over 100, detrusor wall thickness 2 or more millimeters thick, as well as unacceptable risk from bphtool.com. Bladder health baseline is then triggered. The backbone of bladder health baselines is cystoscopy. This is our stethoscope with which we listen to detrusors under duress. The standard level of diagnostic that defenders offer is a combination of cystoscopy with basic urodynamics. If it is available, yes, please add advanced multi-channel and or enhanced if you see fit. Once again, it's our stethoscope. This is the standard level that's built on coupling basic urodynamics with cystoscopy. You can rise the level to elevated by adding enhanced. You can rise the level to high by adding advanced multi-channel. Yes, our goal for all of us is to be able to offer the highest level of diagnostics, and it's dependent on where you are and availability in the world. But at a minimum, defenders offer the standard level of diagnostics. It helps us understand and listen to the bladder to see who is having a bladder at risk, who is obstructed, or who has a weak bladder. The bladders in this situation will always choose and vote for a maximal de-obstruction. But once again, it is willing to compromise. It understands the complexity of good health policy, and one size does not fit all. So to preserve bladder health, we have a battle plan in place, but we also need a report card that tells us as a measure of success how we are doing, especially when we are looking at the plan. These are the 4 P's of better personalized healthcare. So patient advocacy, does the patient feel comfort when we provide the right dialogue, the right data, the right de-obstruction? Do they feel relieved with the planning when we are able to balance the elements of good health policy and map out the next course of action? Do they feel empowered by knowing an honest chance of their chance of success after their surgery? And for prevention, we work together to prevent bothersome fears. For the urologist in the healthcare system, it is the 4 horsemen of the prostate apocalypse. Yes, detrusor overactivity, urge urinary incontinence, acute urinary retention, and detrusor underactivity. But as urologists, we also fear doing harm, violating our Hippocratic oath. There are 2 ways we can do that. One is we can do things that we should not have done, like surgery. We can also harm someone by not doing something that we should have done, like intervening at the right time within the window of curability early enough to prevent damage and dysfunction. And for patients and bladders, these are 5 clinical scenarios that they experience. And yes, it starts off with an annoying slowing of flow, but it can then rapidly escalate and progress to more pressing and more serious levels. The anxiety of urgency and frequency, the exhaustion of nocturia, the embarrassment of the stains and the smells of urine going down your leg, the terror of not being able to pee and rushing to the emergency room for a catheter, and the deep anguish of having a dead bladder in a doomed life of catheters. And yes, we also fear the surgery itself. And so as we transition from preserving bladder health to preventing late-stage BPH BPO, well, the issue there is we need a linguistic frameworks for us to have a discussion about this concept. And it's complex because we have to take very divergent concepts of the 5 clinical scenarios, the 3 stages of bladder remodeling in our academic understanding of bladder health. And we need to converge them, unify them as we evolve into a singular linguistic framework, which is the 5 stages of bladder health. Mr. Smith, did you know that BPH is really about bladder health? There are only 2 major organs you can't transplant, the brain and the bladder. You only have 1 bladder, so we need to take care of it. The heart is a muscle that pumps blood. The bladder is a muscle that pumps urine through your prostate. The prostate is the size of a golf ball in the shape of a mini donut. As you get older, the prostate gets bigger and the donut hole gets tighter and things slow down. That's stage 1. Stage 2, the bladder is now going to struggle 5 years, 10 years, 15 years, pushing urine through that tightening hole. It starts to struggle, quiver, and becomes overactive, creating urgency, frequency, and getting up in the middle of the night, stage 2. Stage 3, if you don't take care of it, the bladder will act out like a rebellious child and squeeze without your permission, causing you to leak urine down your leg, stage 3. And stage 4, if you really don't take care of it, the bladder, just like the heart can have a heart attack, the bladder can all of a sudden stop working and you show up in the emergency room needing a catheter in your penis. And stage 5, just like the heart can go into heart failure, the bladder can go into bladder failure, and you now need a catheter for the rest of your life. Worst case scenario, at least the heart can be transplanted. For the bladder, you're out of luck. You're stuck with that dead bladder for the rest of your life. So the 5 stages highlights how BPH BPO can steadily progress and escalate to more serious and more pressing stages. It highlights the possible consequences if we choose not to take definitive action. It highlights our common goal, which is to prevent our patient from entering these late stages of BPH BPO. And yes, it's not perfect. It's an oversimplification. The transitions are not distinct. Stages can be skipped, and stages can also be coexisting. What started as a simple single voice, a whisper, has now turned into a collective voice. You can download this at ManVsProstate.com. The ebook that I wrote during the pandemic has now been editorialized in prostate cancer and prostatic diseases. It's been communicated in Italian. It's been painted. This concludes part 1. Yes, let's preserve bladder health, prevent late-stage BPH. Use the 5 stages to ignite patients. Urodynamics is your bladder interpreter. Triage for bladder health baselines. Trust the truth of cystoscopy, which is the backbone of bladder health baselines, and deobstruct in the window of curability so we never have to get another phone call at 3 a.m.